I welcome each one of you to this wonderful webinar of the International Eye Care Alliance. This is our second webinar, and I'm very, very happy that we are doing this webinar specifically to commemorate the World Optometry Day, which is celebrated worldwide on the 23rd of October. We're doing it 1 week later. And I wanted to tell everybody that the time officially given of this webinar is 8 to 9 p.m., but we will be extending it up to 9:30 because we have first 3 eminent speakers and then 5 very brilliant panelists, and there'll be very pertinent questions which will be answered by our brilliant panelists also. So stay back to listen to the entire panel. And so the webinar will get over only by 9:30 p.m. Get your dinner out and enjoy your dinner along with this webinar, but do not miss till the end. So I welcome each one of you and I congratulate all the optometrists attending this webinar because it was your day, your special day, which we are celebrating. So welcome to each one of you. I also welcome the ophthalmologists because again, we are meeting at IECA and we are one. You optometrists and we ophthalmologists, together we can do more. So without further ado, let me introduce the first speaker of the day, Dr. Samira Irfan. Dr. Samira Irfan is a highly experienced pediatric ophthalmologist, oculoplasty surgeon, and a dry eye specialist with over 30 years of clinical and surgical experience. She's a gold medalist from Fatima Jinnah Medical College, Lahore. She completed her FRCS from Edinburgh in 1993. She's trained in the UK and she has a long-standing consultant ophthalmologist with a strong foundation in both pediatric and anterior segment care. Dr. Samira, we are now all ready to listen to you. She's going to talk to us about holistic measures to prevent the progression of myopia. Over to you, Dr. Samira.
Thank you so much for a wonderful introduction and the opportunity to be here in this session and to talk about this huge problem, which has really become a pandemic over the last few years. About 30 years ago, the incidence of myopia was only 5 to 10%, as mentioned in the Duke Elder book. But now in the last 2 decades, it has increased drastically. And by the year 2050, it is expected to increase to 50%. 50% of the world population will be myopic. And recent statistics indicate that in Asian countries, 90% of university graduates are myopic. So have you wondered why such a high prevalence of myopia and why is it increasing every year? So while in clinics and explaining the cause of myopia to parents, we conveniently blame it on our faulty genes. But is it truly a genetic fault that has resulted in the myopia pandemic? Research has shown that genetic influence. So have you ever wondered why the faulty genes has been blamed? Research has shown that genetic influence alone is responsible for only 10 to 12% cases of myopia. In the remaining 88%, it's the environmental factors. And their interaction with genetic predisposition causes a rapid progression in those 12% cases. And people have published research papers and PhD theses on this fact. So unless we control these factors, we cannot prevent or halt myopia. So this slide is very important. This is a highlight of this talk. That 2 important facts regarding the pathogenesis of myopia that must be understood is that myopia is a failure of the emmetropization process, which I'll explain in a little bit. And then number 2, for every disease, there is an underlying cause or causative factors which produce the disease effect. So without controlling or removing these factors from this equation, we cannot prevent or control the disease. Scientific research has proven that the main causative factors are environmental, improper myopic correction, and improper posture for causing myopia in the first place and then for its continued progression. Unfortunately, our main focus as clinicians and opticians, optometrists is on controlling the effects of the myopia, which is the increasing axial length. And that is through various interventions that I mentioned, the atropine in glasses, lenses, red light, refractive surgery. So, but please remember that myopia is going to progress for all the study period of a child's life, that is for 20, 30, or even 40 years. So can we continue with these myopia controlling interventions for so long? So now let's look into the emetropization process. What is it and how does it go wrong in myopia? So emetropization is an optically guided homeostatic mechanism by which an eye moves from ametropia to emetropia. A newborn eye is small, 17 millimeter long, and in this small eyeball, the light rays are focused behind the retina, producing a small hazy image. This hazy blurred image, this is the main stimulus that triggers a cascade of events in the retina and choroid, leading to axial growth. Axial growth continues rapidly in an infant to bring the image into focus on the retina. So by the age of 1 year, the eyeball has attained 85% of the adult size, and 45% of the infants, they become emetrope by this age. As the retinal image becomes clearer, further axial growth stops, and as the blurred image signal is no longer there. But now let's see what happens in myopia. Okay, so now let's see what happens in myopia. There's a mismatch between the combined optical power of the lens and cornea and the axial length of the eyeball so that the image is focused behind the retina. The blurred image stimulates axial growth, which continues as long as the stimulus persists. Therefore, myopia is a failure of the emetropization process. And this is also seen in eyes with congenitally blocked visual axis, as in congenital ptosis or in congenital cataract. And then this persists, the blurred image signal persists even after cataract surgery has been done and IOL placed, unless and until the amblyopia is fully treated. Therefore, amblyopia or the blurred image signal is the signal that causes myopic shift in congenital cataract even after the cause has been removed. And this can occur independently in both eyes. So now let's see what is the cause of the blurred image signal in previously emetropic children, toddlers, teenagers, and even in adults. So now let's see what is the main culprit or the origin of the blurred image signal that occurs in previously emetropic children, even young adults in their 30s and even 40s who are now becoming myopic. So the main culprit is the near work, which is continued for long hours. Harmful near work is defined as a distance which is closer than 30 centimeters, and this is equal to 1 foot. So why has near work suddenly become the prime factor in causing myopia in the last 2 decades? The answer is simple: the introduction of small digital screens to young children by their parents. In addition, online classes that were started worldwide during the COVID pandemic for all children, it made the children addicted to digital screens. Once introduced, cell phones and iPads rapidly become addictive, leading to their misuse or prolonged overuse. And the proof for persistent near work as a primary factor in myopia was provided by research demonstrating a higher prevalence of myopia in children with higher IQs and more years spent in studies, with the highest prevalence in university graduates and the least in outdoor workers. There was an interesting experiment in which monkeys that were reared in restricted visual environment of small dim-lit cages developed myopia as compared to those that were allowed to grow in an open environment. So too much screen time, this promotes, it causes 4 or 6 problems, and number 1 is the bad posture. Because small screens are introduced to toddlers, they develop the habit of holding them close to their eyes, bending their heads, and watching them in dimly lit rooms or dark room or lying in bed. And this habit continues when they start school. When they start school, they continue with the same habit. They study sitting on carpets or chairs with side tables or lying down. Now, research has proven that watching digital screens in down gaze, it results in with the rule astigmatism due to pressure of upper lids on the cornea. Astigmatism causes the blurred image signal and the axial growth starts. This I see, daily in clinics, children, the toddlers, or even 4, 5, 6-year-old, they come with high cylinders, -4, -5, and with the rule astigmatism. And when you ask them, the culprit is digital screens, which were introduced when they were 1-year-old. So, and then when they start school, they persist with studying in the same down gaze, and astigmatism and myopia, that increases. Then continued near work, close work it results in convergence insufficiency and exotropia. The child now is studying with only one eye, the other eye divergent, and therefore the load, all workload, it falls on one eye, and convergence insufficiency, and as well as accommodation insufficiency. The result, as the accommodation, it reduces, there is a hyperopic defocus, blurred near vision, and again, myopia and astigmatism. And though the story continues. So in addition, the prolonged near work, particularly in down gaze, research has proven that it results in reduced choroidal perfusion during near work. Since sclera is dependent upon choroidal blood flow, reduced choroidal perfusion leads to scleral hypoxia, scleral thinning, and then the sclera starts protruding outwards in response to increased intraocular pressure that also occurs when studying in down gaze or lying down. Then focusing on digital screens, it results in chronic image degradation and promotes dry eyes. When the cornea gets dry, the image gets blurred. And again, the same story, the stimulus starts and myopia, it progresses rapidly. Then also studying on digital screens rather than on books, it reduces the image clarity, its contrast, as there is a flickering background, there is glare and reduced contrast. Therefore, this requires more focusing power, more accommodation, and a strain of accommodation, as well as on convergence. Then nighttime studying, many children as well as adults, they are hooked on to this habit of nighttime use of digital screens in dimly lit rooms. This is extremely harmful as it results in altered circadian rhythm. It blocks the secretion of essential hormones like melatonin and dopamine and cortisol. These disrupt not only the emetropization process, but also general body growth and mental development in children. Therefore, to halt myopia, we need to have a holistic approach to that must be adopted by ophthalmologists, opticians, and optometrists. So that holistic approach comprises of these A, B, and C steps. That A is proper myopic correction, B is proper posture during near work, and C is the environmental factors. So let's see what is proper myopic correction. Proper myopic correction is described as dispensing proper glasses for far and near, the minimum spherocylinder that gives a maximal visual acuity. So for children as well as adults, that has to be understood that under correction, that has to be avoided at all costs. Unfortunately, it is a general practice by clinicians and opticians to undercorrect myopia, which I actually fail to understand why. So I hope somebody can enlighten me why. So undercorrecting myopia is criminal. This practice is extremely wrong, as undercorrection continues the blurred image signal, and myopia continues to progress. And this is particularly true in cases of astigmatism. Opticians and clinicians, both, they are so scared of giving full cylinders to children. Now, undercorrection, how can undercorrection give a clear image? And as long as the image from the retina, despite wearing glasses, is blurred, the blurred image signal is going to cause myopic progression. As you see in this diagram, if the child needs 5 diopters of correction and you are giving 4 or 3, the image is still blurred. The rays are focused in front of the retina. So that blurred image signal is there all the time for near and distance, and myopia will progress. This is, I borrowed the slide from this smart optometry. And they have explained it nicely that the red is again under correction by 1 diopter. And then, but when the correction is full, that is in myopia of 2.5 diopter, you are giving 2.5, the rays are focused on the retina for far, and the blurred image signal disappears. Similarly, if you are overcorrecting, even overcorrection by 0.5 diopters, the rays are being focused behind the retina. There is a hyperopic defocus, and again, blurred image, and myopia will start progressing. So please remember that to stop myopic progression, you have to get rid of the blurred image signal. As long as the blurred image signal is there, you cannot halt myopia. So whether it's undercorrection of sphere or cylinder, or even a slight overcorrection, they are both equally harmful. Then another important point for children, they must be made to understand that the glasses that you're giving for far distance, they are the same for near distance. Why same? Because they have a strong accommodation reserve. They have strong accommodation. So same glasses, if you are giving 4 for distance, you have to give 4 for near. But in adults, because the accommodation amplitude is reducing every year, after the age of 20, the accommodation amplitude has reduced by 50%. So after the age of 20, 22, 23, for near, you have to reduce the myopic correction by 0.5. You must do a subjective refraction for near, reduce, add 0.5 in the spherocylinder that you have given for distance, and make the patient read the book at their proper reading distance, not 30 centimeter, but about 2 feet away. That 2 feet or 2.5 feet should be the minimum distance at which book reading by everyone should be done, children and adults, and with the head straight, and book should be straight. Eyes and should be looking straight ahead with the neck straight. And so for adults after the age of 20, 22, 23, a small near ad or 2 glasses, I always give them 2 glasses, 1 for distance, 1 for near, with a small ad. So this hyperopic defocus is gone. It's no longer there, as the accommodation amplitude is reducing after this age. So another important cause of undercorrection in children and myopic progression are bad frames. Children, they walk in my clinic, and these are the kind of glasses they are wearing. They are looking through the upper half of the glasses. Proper centration of glasses is extremely important. If this is our job as clinicians to see what kind of glasses child is wearing. And if they are daily watching through this kind of glass, then the maximum number that we have prescribed is in the center. But when the child is looking from the upper half of the glasses, there is undercorrection by 1 or 2 diopters. So this must be corrected. Proper frames, this is our job, our responsibility. So as you see, children, they have different faces, and then they are never sitting still. They are moving all the time. So they need properly centered, properly tightly fit frames. The frame should be centered in front of the pupils. And then important thing about the frames is that children's frames, the weight of the glasses is supported by the nasal bridge and the ears. So the bridge of the glasses, this should rest comfortably on the nasal bridge. But if the bridge is high, the eyes, they will come at the level of the bridge. So for glasses in children, the bridge should always be in the center of the glasses, in the center, because at the level of the bridge, the eyes will be there, and that will be centered in front of the pupils. Then another important point, the frame is supported by the ears, so it shouldn't be loose. The sides of the frame should be curled. They should be curled. If they are not curled, you can have these supports, and they can be added to the frame, or they can have elastic headbands so that when they are moving, jumping around, the frames are properly centered in front of the pupils at all times. They shouldn't be loose. So these things are important because undercorrection is a very important cause of myopic progression. Then it is our job, number B, proper prescription. Proper now posture. Proper posture during near work, it is the mainstay of myopia prevention and control. Proper posture avoids astigmatism because down gaze is gone. No with the rule astigmatism. Then it prevents accommodation lag, convergence insufficiency, and hyperopic defocus. So make children study on these inclined tables with the proper chair and the back straight, the neck straight. So I advise my patients, the parents, to buy these kinds of tables, have them in schools, and so they study at home with these. And then minimize near work, because near work is the main culprit, that it shouldn't be less than 30 centimeter distance to avoid, again, convergence insufficiency, accommodation, and choroidal perfusion. And then controlling environmental factors. So control the blurred image signal by making children study, or even adults, in well-lit rooms, back straight, supported, chair pulled in towards the desk. Reduce screen illumination and contrast, increase the font size, and they must follow the 30-40 rules. American Academy has given the 20-20 rule. After every 20 minutes, take a break of 20 seconds to look 20 feet away. I think that is unrealistic. Nobody is going to get up after 20 minutes. So 30-40 rule is to 10. After 30-40 minutes of studying, make the patients, the children or adults, they get up from the seat, just walk around for 5-10 minutes and then come back. So this is, I think, more realistic. And then encourage book reading rather than studying on digital screens, because all this LED technology, it uses short wavelength flickering background that creates glare and reduced contrast, small font size. Then high resolution devices have high pixel density, and they require close viewing to appreciate fine details. And therefore, books, they are much, much better to reduce contrast and glare and asthenopic symptoms. Ban nighttime use of digital screens and studying. Make that a habit for children. And then encourage daily outdoor activities. Everybody's saying go outdoor, but do you really know why going outdoor is beneficial? Number one, vitamin D. What does vitamin D do? It reduces scleral remodeling, and increases scleral thickness. Daily outdoor activity, it increases dopamine, which is required for neural signal transmission, and it stops axial growth. Then when we are looking at far objects outdoors, we are relaxing the accommodation and convergence, and the hyperopic defocus disappears. And while we are going outdoors, the children are going outdoors, they are less inclined to use digital screens. So encourage them to go out because of all these 4 reasons. Then the parents must be made aware that early and regular ophthalmic checkup before starting school is extremely important to curb the situation, to make the children adopt proper study habits, and they should have a proper assessment. If they start wearing glasses early and myopia is caught early, it can be prevented from progression. Desktop computers should be encouraged rather than studying on small cell phones. And proper furniture in schools, proper study rooms, well-lit, spacious, airy, with regular hours of uninterrupted sleep at night for 8 hours to maintain the circadian rhythm. So atropine, everybody is hooked on to low-dose atropine, but my only question is, it is good, but how long are you going to continue it? For 40 years? Myopia is a disease for the next 30, 40 years. How long are you going to continue it? Then again, the DIMS, the halt glasses, they all have a central aperture where there is a proper myopic correction, and then the periphery to reduce the hyperopic defocus. So these are all expensive glasses. A parent has 4 kids. Are you going to give all these 4 children these glasses? And then they need to be changed every 6 months. So how can one afford? The other solution is to control their study habits, to adopt proper study posture, and hyperopic defocus and accommodation lag will disappear. You will not need these expensive glasses. So orthokeratology, again, the cost, trained technician, regular supply of these lenses, and every night the parent or the technician has to fit the lenses so that in the morning the cornea is compressed and the myopia disappears. But then can this continue for 30, 40 years of a child's life? Now, next is red light therapy. Nobody knows the red light that is focused on the fovea. What are the long-term effects on the cones and ganglion cells? So I don't advocate all these. I believe to treat the cause, to treat the environmental factors, which are better and more efficient ways to halt myopia, rather than focusing on all these other interventions. So all these whatever I've told today, they are in this book, which is available for free download on ResearchGate. So please feel free. And look, technology, it was there to serve us. It should not enslave us. So all of us have to strive to save our children's health and eyes. Myopia is not a disease of 1 year or 2 years. It is going to be there for lifelong. We need lifelong solutions. It is a disease of altered lifestyle. So we have to adopt measures to change our lifestyle to where it was before it all started. Thank you very much.
Dr. Samira, it was such a treat listening to you. And there were many, many valuable insights, which I think all of us must have gained from your talk today. So thank you very much. I wanted to share that there were 3 things which I feel I need to bring out, which I have personally learned from your talk, besides many other things, is that how exactly poor posture can also cause the progression of myopia, and how in adults after the age of 20 years, by giving them a small low ad for reading, you again reduce the hyperopic defocus. And of course, something very simple but so important, that for children in the frames, the bridge should be in the center and not on the top. So I think wonderful, Dr. Samira. Thank you once again from all of us here. Thanks a lot. And please stay back for the panel discussion. I now invite Dr. Kalpa Neguloni. Dr. Kalpa Neguloni leads the clinical research at Remidio Innovative Solutions, and she brings over 17 years of experience across clinical practice, pediatric eye care, and ophthalmic research. Her work focuses on developing and validating diagnostic technologies, particularly for early detection and management of myopia in children. She has multiple peer-reviewed publications and is actively advancing evidence-based eye care. So who better than Dr. Kalpa to deep dive with all of us into myopia and tech-driven myopia care? So over to you, Dr. Kalpa.
Thank you so much, Dr. Samina. And Dr. Samina, it was a wonderful talk, and thank you so much for stressing on the environmental factors and its impact. So I think that was really, very important that you stressed upon. I'll quickly share my screen. Please let me know if you can see my screen.
Yes,
Can you see
Dr.
my screen,
Karpa.
doctor?
Yes, very much. It's very clear. Thank you very much.
Thank you. Hello, everyone, and thank you, Dr. Samina and International Eye Care Alliance, ICA, for the invitation. And to all the optometrists who are here, wishing you a very happy World Optometry Day. And I myself am an optometrist, and it's really a great opportunity to reflect how our role is evolving in today's technology-driven healthcare ecosystem. And just to state my disclosure upfront, I'm with Remidio Innovative Solutions. And in this talk, I'm going to give some examples of Remidio technologies. However, this is more purely in terms of illustrating the care pathways and the clinical concepts, and not for any commercial promotion. So today I'll be speaking on the technology-driven myopia care, and more importantly, how an optometrist can play a central role across the entire patient journey, right from screening to the long-term myopia monitoring. So myopia is no longer just about correcting vision. All of you know that the burden is rising with urban more than the rural population, and the progression matters. So it's not just the diopters. We also look into other things like the axial length and so on. And the care today is fragmented without any continuity. So here the real gap is that the care stops at only prescription, while there is definitely a need for ongoing technology enabled monitoring and progression control. So when you look at the prevention of myopia, I think myopia starts, before even myopia develops or progresses rapidly. I think as an optometrist, its role begins with identifying the risk early. So when I say risk early, it's more of recording the family history or age of onset, and then the baseline axial length, and so on. And also, it's important that we encourage the behavioral changes like outdoor activities. I think the previous speaker has beautifully, Dr. Samira has beautifully stressed on the outdoor activities, working distance, lighting, and other environmental factors. And also, we also look into the early signs like squinting of the eyes, or headaches and sitting closer. Those are certain things that we tend to miss and then take it for granted. So here the key is that the delay onset, and the we prevent children from entering into something called as a fast progressor phase. So any child enters through the system of this through multiple fragmented touch points. Say at a school screening programs, or they visit pediatricians, and we could also look at identifying them at a pediatric center, or they may visit an optical store, and there are different touch points where the screening can happen. So real problem here is not detection. We are definitely very good at detecting and that phase of the journey. But however, the main problem is that the children tend to drop off after the detection. So we all know that there are several factors to it, but again, there is no continuity, or in fact, I would say there is no ownership in terms of the child's long-term care. So here, every touch point, whether it's a school screening program or a pediatrician office or anywhere, I think it should be like screen, assess the risk, and then you trigger a tracked referral and a follow-up pathway. So here, I feel technology can definitely play a critical role in terms of bridging this gap. So so we need to move from, as an optometrist, we need to move from an episodic refraction that we have into a closed loop care. So when I say that, it can be first phase as finding by doing myopia by screening at a large scale, and then confirm it by doing a comprehensive evaluation, and then quantify the risk, which is very very critical in terms of whether it's axial length or age, or take a good detailed history in terms of all the risk factors that are related to myopia, and then you intervene by providing the appropriate tailored treatment method. And most critical aspect is monitoring them every 6 months or 12 months, and also look at the behavior changes that happens with regard to the intervention and how it is over the time. And finally, you escalate if the progression continues. So here, I would say that, and ideally, if there is an optometrist-led monitoring pathway and along with ophthalmology escalation rules, then I think that would be the best way, along with technology that can help in terms of ensuring that there is an objective way of quantifying it, and there is a protocol or a scalable model, so that that helps in bringing the child to an appropriate care in terms of monitoring and follow up. So here, the most important shift will be from we prescribe and forget to a protocol-based long-term care. So now I'm going to split the technology into three different parts. One is on the screening, and the second thing on in terms of the treatment, and in terms of the so when we look at technology in screening, there are different entry points, as I shared before. Like it could be a school or a pediatrician office or even general ophthalmology clinic or an optical store. But there are also different innovative technological tools that each of this can be used in terms of better triage to a myopia management funnel, I would say. So when we look at technology in terms of diagnosis, so diagnosis could be an optometry-led model where technologies like accurate refraction, biometry, or a topography and a binocular vision assessment and can be done. And along with that, you look at the established baseline and also monitor the treatment response over time. And here the and also get the support in terms of ophthalmologists in terms of if there are challenges with regard to this care, and also where there are other important interventions like atropine therapy and other newer technology, the other solutions that have come. It's important that there is a co-management model, I would say, that can help in terms of every child that has myopia and how best we care and work together. So the next is technology in treatment. I'm not getting into we know that there are different treatment models available, whether it's an optical intervention or contact lens or spectacle lenses and all those. I'm not getting into that. And here is a beautiful Cochrane review which shows, how much of an axial length and a spherical equivalent change over 1 year or 2 years based on these intervention types that are there. But however, I would say that this treatment also depends on a lot of factors, and like multiple factors, in fact. And here, if you look at, like, for example, this is an axial length growth curves that you see on the top. So it beautifully gives you based on the data set. So we have different ethnic population data sets that are available in terms of looking at what is the axial length change over different age groups. So it's a beautiful growth curve, and you can also this would help in terms of counseling the parent in terms of what is the risk that a child has. And this is somewhere a technology can beautifully help in terms of collating a large data set and then developing such a model. And the second one that you see here, and sorry, it's very small, but I would just brief you that these are based on different treatment modalities, whether it is the orthokeratology or different level. You have, if you record the axial length and the refractive error at the baseline, and when the child comes to you for a 1 year follow, you can look at what is the change that happens and what is the change over time based on the database that the model is feeded and trained on. So it's really good in terms of, but again, caution of care. As a clinician, it's very important that you also look into what kind of a data set is used, and whether it is appropriate for your clinical practice as well. So in a nutshell, like, technology definitely plays an important role, but it can also tell you what kind of a treatment is can be chosen, and also whether the how is the control of the progression over time, and so on. And even for a parent, I feel this is a good tool in terms of sharing what can be the best care. And if you look at AI, the artificial intelligence, I think there are enough evidence in terms of, or a growing evidence in terms of how an artificial intelligence system can support at multiple levels. So at starting from screening in a scale to risk stratification and then decision support. And most importantly, I would say that AI is again not to replace any eye care professional, but it definitely helps in augmenting the decision making, and it helps in standardizing the care, reducing probably kind of a variability, reducing the variability kind. And also, most importantly, it enables in a large scale screening. So here you see an example of chat myopia, which is an AI agent which was used in a primary healthcare center. And you also see another, a fundus image-based myopia prediction models, which have shown good AUC and have been implemented in large-scale screening, at least at the first level, to triage these patients to the, the care loop. Globally, I think there are increasing consensus in terms of, as you see, the important global myopia groups. In terms of axial length is definitely essential for, it's important to be monitored, and refraction alone is not sufficient. So here I would say that myopia management is definitely shifting towards more objective and longitudinal metrics. So this definitely reinforces a need for better tools that can be, that can have a standardized protocols and so on. So, myopia care is definitely unique, I would say. That's because, see, it creates an recurring engagement over years. Say, for example, if a child enters the clinic, then there are at least 5 to 8 years follow-up period. And if you look at the revenue streams, that includes monitoring, optical interventions, and advanced treatment that are there. So here the key point is that it's not just a clinical impact, but it also gives you a sustainable care model for practices. Say, for example, if you invest on one device, so which is around 17 lakhs, and if you look at the annual per patient, then it definitely varies based on the interventions that you provide. So say over time, if this 1 year builds momentum, then you can have an breakdown achieved around, say, 1.5 years. So here the most important takeaway is that technology can definitely enable both clinical care and also a viable long-term practice economics. So so I would say that optometrist can be a monitoring hub in terms of measuring, monitoring, and also looking at the treatment tracking. Of course, through the different screening loops on the left side that can help in triaging this patient, and also get supposed from the ophthalmologist and also other technology driven providers in terms of bringing in the right set of instruments into the practice, so that at the end it is more towards the effective myopia care that has an co-management workflow together. So optometrist, I would say, to summarize, optometrist should be a clinical anchor of longitudinal myopia care. And I think right now India definitely has enough data to build its own scalable myopia care models. And like AI, again, this technology is not a replacement of any of the eye care professional. It just simplifies myopia care and making it more measurable, connected, and longitudinal. So thank you so much, everyone, and thank you, Aika, for the wonderful opportunity.
Thank you, Dr. Kalpa. It was really wonderful listening to you. And I do agree with you that technology is needed now in the care of myopia, because all of us understand that myopia is an increasing burden in all over the world. It's important that we are able to, detect pre-myopia, and if not, if the child becomes myopic, to detect and predict progression, so that we can, like what Dr. Samira also said, that holistically prepare the parents and the ecosystem of the homes to reduce the progression. So a simple graph, if it comes out, say through an OBM machine, it becomes much more easier to convince the parents that if not, your child's myopia is going to progress. So I'm going to have our panel also talk about this definitely. But thank you so much, Dr. Kalpa. And over now to Dr. Vasudha Kemanu. Dr. Vasudha Kemanu is a distinguished pediatric ophthalmologist with over 25 years of experience, specializing in strabismus, amblyopia, and pediatric cataracts. She's trained at Shankar Nethralaya and holding a master's in public health from the University of London. She's a Commonwealth scholar. She's also an active member of SPOSI and WSPOS, contributing significantly to the pediatric eye care. And she is a mentor for our Children's Eye Centre and our advisor for our community initiative. So thank you, Dr. Vasudha, for all what you do. And over to you now. Dr. Vasudha is going to talk to us about rethinking myopia through the public eye health lens. Dr. Vasudha, you can share your screen now.
Thank you very much, Dr. Samina, for this introduction and for inviting me to speak here. I will share my screen. Is this visible?
Yes, Dr. Vasudha, it's visible.
Okay, so actually, I must say that Kalpa has talked a little bit of this primary, secondary prevention and all that, so she has made my work easier. But let's move on, and we will start rethinking myopia now through a public eye health lens. So the traditional view is that of myopia's optical state, that it is simple, benign refractive error, and it can be treated with glasses, contact lenses, or refractive surgery. And I remember maybe 10, 15 years ago, it wouldn't take much time, the chair time spent by an ophthalmologist to treat myopia was very less. There was nothing to counsel or anything. You give them glasses and ask them to come after 1 year. That's all. But now we have a re-evaluated view that it is a biological process, the clinical expression of which is excessive axial eye growth with tissue stretching. And of course, there is public health burden. It affects schooling, productivity, access to care, equity, and future retinal disease burden at a population scale. So from refractive state to structural disease, the real concern is not only blur, it is the tissue that is at risk. So even if a patient achieves 6/6 with correction, he or she is still accumulating lifelong risk. And there can be visual impairment later in life despite good refractive correction in childhood, and this would impact the quality of life, productivity, and increased burden on tertiary eye care at a later date also. So, when you think of myopia through a public eye health lens, these are the facts that we need to know. WHO estimates at least 2.2 billion people have near or distance vision impairment, and refractive error is the most common cause. And productivity loss from uncorrected myopia is huge. US dollars 244 billion, it seems. And in low income countries, 2 out of 3 people who need spectacles do not have access to them. So, myopia sits at the intersection of vision, equity, and systems. So, this, I think all of us have already talked about it. The global prevalence by 2050 is going to be 50%. And see, out of that, 10% are going to be high myopes. And in India, it is the same thing. Around 48% of the children are said to be myopic by 2050. So our burden is only going to increase until and unless we really think of doing something to prevent progression. So what are the determinants of myopia? These are beyond the eye actually. So Asian ethnicity, urban residents, higher education, heavy school curriculum, high near work demand, female gender, adolescent age, and prematurity. These increase the risk of myopia. And of course, all of us know that genetics are one of the cause, but on that there is a huge environmental overlay, and that is most of the time behavioral. That means too much near work screen, too much screen exposure, and very less outdoor time. And then there are also the determinants. It could also be policy level matters like school schedules, education policies, lack of outdoor mandates. And we must realize that clinicians alone cannot modify these determinants. See, for example, when I tell my patient, maybe studying in ninth, 10th, or 11th standard, that please decrease your screen time to less than half an hour, you know what they tell me immediately? That their homework comes through WhatsApp group, and that is in the form of a PDF. And they say it takes around 3-4 hours. So now, what can I do? What can the parent do? Actually, or what can the child do? Sometimes I tell them take printout because your myopia control is very important. Take printout of that and do, but that is not always, doable. So that is why I say clinicians alone cannot modify these determinants. Then, so what exactly is driving this epidemic? Genes matter, but environment is amplifying expression. So the formula, according to me, could be something like this: genetic susceptibility into educational pressure plus urban indoor lifestyle plus screen time minus outdoor time. That is equal to accelerated axial elongation. And that causes earlier onset of myopia. And earlier onset means, what does it mean? More years of progression. And what does that mean? Higher lifetime risk. So this is the main problem. So how will we rethink myopia care through public health angle? So there is this primary, secondary, and tertiary prevention. So primary prevention, main thing that we need to do is, this is before the onset of the disease itself. So outdoor time promotion, school-based awareness, and parent education. Secondary prevention is early detection in schools and identifying fast progressors so that they don't progress. At least give them glasses, let them see well, let there be no blur. Tertiary prevention will be evidence-based myopia control like optical, pharmacological, and behavioral, and monitoring and follow-up. So this is a life course model for myopia. The goal is not only clear vision today, but to lower the lifetime ocular risk. So these 4 components, we will talk about it one by one. So pre-myopia, this is preschool. What we need to do here is identify at-risk children, those that have family history and those that have low hyperopic reserve. So what can we do and how can we achieve this? For this, I feel that we need to have a policy mandate where the eye examination of every child is made compulsory before the child enters school. It should be like, if there is no eye examination, there will be no admission. That is a very important component of admission to preschool itself. So that, and then again, this thing can be repeated at first grade when the child enters maybe around 5.5, 6 years of age, when they enter first standard. See, again, this has to come from the government. Until and unless there is a policy, it is very difficult for people to follow it. Then the second thing is onset prevention. This is during the school hours. So the main thing that can be done is to increase outdoor exposure, counsel families, and work with schools. So this is a study that was done in Taiwan. And in 2001, it seems when they saw the prevalence of reduced uncorrected visual acuity, it was 34.8. And then it kept increasing to around 50% till 2011. In 2010 September, they brought this policy, that is the Taiwan Tian Tian 120 policy. I don't know if I have pronounced it right, the Tian Tian thing. That is supposed to be everyday 120. Everyday 120 means the child has to have an outdoor exposure for 2 hours every day. And when they did that, they found that it decreased to 46.1% by 2015. And they also have a school-based randomized control trial data which says that outdoor promotion reduced myopic shift, action length elongation, and rapid progression risk by 54%. So that is huge. So this is one thing that we need to do. If you see, if you ask I have asked so many of my patients, especially in the older classes, that means 8th, 9th, 10th to 12th, the PT period where they are supposed to go out and play is taken up by the math teacher. So they hardly have any kind of outdoor exposure. So this thing also will have to come out as a policy. Then progression control. This will be, okay, you have fit the child with glasses. So now you don't say, okay, go home now, you are fine, you can see well. That is not the end point. The child has to be monitored regularly, and we will have to start the low dose atropine or maybe myopia control glasses or contact lenses or ortho-K, anything that is correct for that particular child. And after that also, the story is not over. The child is 18 or 21. Nowadays, we have seen progression up to around 21 years of age. So child is 21 and then you cannot say, okay, now it is over. No, it is not. That child will grow into an adult, and the adult would require lifelong monitoring for retinal glaucomatous and macular complications. So we have to educate patients about the importance of lifelong routine checkup. So what are the main challenges that we are facing? Actually, low effective refractive error coverage is there is a recent study in the Lancet Global Health, and they say it is low. That means it is around 65.8. It seems in 6 units only. And the other thing is coverage, the refractive error coverage is low, very low in low income countries. And inequities persist by gender, age, geography, affordability, and service availability. The same system weaknesses that limit spectacle coverage will also limit equitable access to myopia control. That is what we are trying to say. There is low REC, so that same thing there will be to myopia control also. So the other challenges are school screening is focusing only on detection, not prevention or control. Myopia is treated as give glasses and forget about it. So there is lack of standard referral pathways for myopia control. And the missed opportunities are early onset detection, risk stratification, and parent counseling. So screening is not equal to disease control. That we must remember. So this WHO SPECS 2030 initiative, this calls for a global action among stakeholders across 5 strategic pillars, this SPECS. So we will talk about each one. The first S is service design. So how we can modify it to myopia. So we have to integrate myopia screening into school health programs, establish proper referral pathways, develop standardized protocols for myopia detection and management, and ensure availability of myopia control options. This thing will have to be done by any eye health facility. I think it is the responsibility of all of us, eye health facilities, anybody who goes to an eye hospital. It is all our responsibility. We need to do this. If it is not being done, I think it is high time we start doing this. So the second one is capacity building or personnel, SP. So here we need to train teachers, and if we could go one step ahead and train primary health workers for early detection, then it would be excellent. If not early detection, at least we could make them aware of these, what are the risk factors of myopia. We must remember that these primary health workers are the closest to the community and they can do a lot of things. And we have to upskill optometrists and ophthalmologists in myopia control strategies. So the third one is education of the population, educate parents on early signs and progression risks, and encourage healthy visual habits. So again, this thing, most of us, I think we do school screening, but we just go, we see the visual acuity, and those that have a reduced uncorrected visual acuity, we refer them or we provide spectacles and we come back. But how many of us actually educate? Do we have a video session or do we have a session with the parents? Can we call the parents when the screening is going on? Can we talk to them? Can we educate them? At the same time, we educate the teachers also. Then cost reduction. So developing low cost screening models. Actually, see, this school-based screening model, it is proved that it is very cost effective. Already studies are done and it is proved. So that is okay, because you see a large number of children are there in a smaller area. So it is much easier to screen them. The other thing is to subsidize spectacles and myopia control interventions, which I think is really, I think we have not done much in this area. We could discuss this later, because if we screen government and government aided schools, and if we tell them to use low dose atropine for another 6-7 years, do you think they can afford that? Or myopia control glasses. Cheapest one would be, I think, 7,000. Where will they go for 7,000 rupees? And maybe in 6 months or 8 months or 1 year, they have to change again. So this particular thing, according to me, requires a lot of zeal from our side. And the fifth one is surveillance and research. Again, I think we should take that responsibility. Each eye organization, clinic, institute, we should take the responsibility of research. It is not that, okay, you see this patient, send him home, fine, everything is okay. Until and unless you monitor the prevalence, what is the progression trend, what are the outcomes, are the patients adhering to the treatment options that we have given them, and we should help in identifying high risk populations and geographic clusters so that it can generate local evidence for policy. Now, if I am working in Bangalore, I will see that maybe there are a lot of patients with myopia. If I go to a rural place, maybe I see that it's not much there. Even now it is beginning to increase, but it may not be much there. So we could tell the government that, see, it requires these things. Urban schools should definitely have all these things done. Rural schools, maybe we can wait. I'm just giving an example. But until we take up the responsibility of research, I think it will be difficult to do any kind of public eye health, or even in other areas. We will not progress. That is the problem. So these are the 5 pillars of SPECS 2030. So now the ophthalmologist's role must expand. So we have to identify early. We have to standardize the protocols. We have to build proper referral pathways, like linking the clinic, optometry, public health programs, everything together, and leading the surveillance, like advocate for school-based prevention and lifelong monitoring for high myopes. So To conclude, I want to say that myopia is not just a refractive error. It is a public health priority. It is not correction alone is not enough. Prevention and control is very important. Isolated care is not enough. It has to be integrated into systems, into public eye health systems, if it has to be sustainable. And we should understand that there is no equal access today. A government child going to a government school or a government aided school has no access, whereas children who are well off, they have more access. So equity must lead. So rethinking myopia today is essential to protect the vision tomorrow. Thank you.
Dr. Vasudha, I think you really threw light on an area which not many of us think about, that you really can't work as an individual. All have to work together. And that's where I think ICA will also play an important role to see that ophthalmologists and optometrists work together in this fight against myopia. So thank you very much. And now, yeah, if, so I'm now going to uh, I'm very excited to introduce the very brilliant panel who is there with us. We'll start with Dr. Rajiv Prasad. Dr. Rajiv Prasad, if you can please on your camera, that will be helpful. Dr. Rajiv Prasad is a global leader in optometry, currently serving as the president-elect of the World Council of Optometry and the president of the Asia Pacific Council of Optometry. He's also Secretary General of the Indian Optometric Association and founding president of the International Academy of Myopia Control, the India chapter. He's the founder of the multiple key initiatives like Visualize India and Gurukul. So welcome, Dr. Rajiv. The next, I will go to Dr. Mohita Sharma. Dr. Mohita, if you're here, please on your video. I think we all know Dr. Mohita Sharma, but let me formally introduce you. Dr. Mohita Sharma is a renowned ophthalmologist with over 30 years of surgical experience, specializing in cataract, LASIK, and other refractive surgeries. She's a founder and chairperson of the Tirupati Eye Centre and Research Institute in Noida, one of North India's leading eye hospitals. She's a pioneer for women in ophthalmology. She founded both the Women Ophthalmologists Society and the Women Ophthalmologists Worldwide, driving global collaboration and leadership. And I will congratulate you to be recently elected as a joint secretary at the AIOS. So welcome, Dr. Mohita Sharma. And now we welcome Dr. Vinod Arora. Dr. Vinod Arora is the director of the Nivora Eye Institute, a highly accomplished refractive surgeon and academician with an extensive global presence. He has presented over 800 papers and published 30 papers, earning multiple prestigious awards, including the IRSI Gold Medal in 2017 and the ISCKRS Excellence Award in 2023. He's known for his innovative teaching formats, and he continues to contribute actively to surgical education and research. Welcome, Dr. Vinod Arora. Now I take Dr. Jitendra Jethani. Dr. Jitendra Jethani is a very senior and experienced pediatric ophthalmologist and director of the Baroda Children Eye Care and Squint Clinic, one of the largest dedicated pediatric eye centers in the Western region. With over 22 research awards, 70 index publications, and 250 plus presentation, he's also pursuing a PhD in myopia progression. He's an innovator and author known for advancements in strabismus management and diagnostic tools. And congratulations, Dr. Jitendra, for recently getting inducted in the Leadership Bureau of the World Society of Pediatric Ophthalmology. We welcome you, Dr. Jitendra Jethani.
So much, ma'am.
Thank you. Now, last but not the least, Dr. Senthil Kumar. Dr. Senthil is an entrepreneur and an innovator in ophthalmology practice. I think we all know Dr. Senthil for Ophthal Practice Development Forum, which is doing wonderful work in India and much needed work actually to empower individual ophthalmologists and entrepreneurs. So he's supporting about 6,500 eye care practices across India. He's also the founder of the WellCare Health Systems, and he's also launched Ophthalmart, India's first e-commerce platform. And recently, he has started an academy for training optometrists. So we'll be listening to him more about the academy also. So welcome, Dr. Senthil Kumar. So now, quickly moving to the questions for today for the panel. My first question will be for Dr. Jitendra Jethani. Dr. Jitendra, as somebody in a leadership global forum for myopia and pediatric ophthalmology, what is your take on predicting the progression of myopia, the tools? What about pre-myopia detection, and what about the less known low red light treatment? But what do you think is the future of the low red light, and any other newer innovative tools which you feel is the future of myopia management?
I'll just say that thank you so much for the invite and the wonderful talks by Dr. Vasudha. And even better, that we can talk about pre-myopia, because pre-myopia is something which is an actual disease which can be prevented. We are at a place where we can think of, treating or rather preventing the onset of myopia. So there are just two important points. One is that, I think the future would be that we will have a lot of AI tools, as Dr. Kalpa rightly presented in her presentation. Remidio has a device. Even if you don't have OBM12, there is bhvi.org. There is a myopia calculator. You can access it. It gives you wonderful insight on which patients can become myopic in future. So I think that is where we would be going eventually, because we all will be having multiple calculators. Just like right now we have IL power calculators, we will have risk factor analysis for pre-myopia. And I think one of the major task of one of the major tasks of WSPOS or other forums at this point of time in pediatric ophthalmology also, one of the most burning tasks is indeed to find out who would be converting to, myopia. And so I think a lot of the most important question is that, once the patient becomes myopic, it is difficult to stop the progression, and most of the patients who become myopic would be progressing. But not all pre-myopes would become myopes. And so it is very important to diagnose which patients are at risk. The point about treating pre-myopes is entirely different one. The point about identifying which patients are at risk would be a huge task. So I think that is also a very important point, that, if we can find out which patients are at a risk, then we can appropriately advise that, yes, these are the lifestyle modifications which are needed, and they should be done first.
Thank you, Dr. Jitendra. Thank you for your insights about pre-myopia. Maybe we'll come back to you to know more about the low red light, in case if you can throw some more light on it. But now we move on to the optometrists. We have three leaders in optometry with us today: Dr. Rajiv, Dr. Gaurav Anand, and Dr. Neha Prashant. And I'm going to ask the common question to all the three of them: that what do you think is the role of organizations like the Optometry Council of India, where you have a leadership position, is their role in this fight against the myopia, uh, working alongside ophthalmologists? What do you think that these organizations can do to bridge the gap between ophthalmologists and optometrists, and seeing that we all are aligned for the common goal? Myopia is one of the things, but besides myopia, other causes of avoidable blindness, how can we work together? So we don't have much time, but quickly, Dr. Rajiv, then Dr. Gaurav Anand, and then Dr. Neha Prashant.
Yeah, thank you so much, ma'am, for this opportunity. I think, first of all, congratulations to everyone, for joining us at this IKEA second webinar. And, this is a very important question. See, as an organization, there's one small correction. It is Indian Optometric Association, which is the only statutory body of the country. So when we look at myopia, it is very clear that there is no single, way we can take it forward. And we all have the responsibility, and not just to advancing on optometry, but, to move ahead with collaboration, across the entire ecosystem. It is really important. And, working alongside as an optometrist, I would say, it's really important that we should collaborate and work alongside with ophthalmologists. It's not about, just desire or not desire. It is all about, it is really, really required. That's the need of the hour. And myopia today, we all know that it is a public health concern. It is not no more just a refractive issue. Right from early detection, like Dr. Jitin was mentioning about pre-myopia, to long-term management, and both ophthalmologists and optometrists has to complement each other to strengthen the table. On ground of World Council of Optometry and Indian Association, I think we'll have to really work on how to create a campaign that speaks about with one voice. We have to really go deep down and educate parents, teachers, and policymakers about the lifestyle factor. I mean, definitely there are various other things which we have to get into, but one common thing which definitely we all can do, just word of mouth publicity, is all about the lifestyle changes which is required, like outdoor activities, less of digital exposure to kids. And I recently heard that probably there's something coming up which says that children below 3 years should not be exposed to digital devices. Secondly, we'll have to work on evidence-based advocacy by aligning both the bodies together, and we'll have to work on how optometry and ophthalmologists can work on to the national health program, ensuring accessibility, and definitely affordability will be another big challenge in the treatment options. What we have beside atropine, we have myopia glasses, which is definitely on the higher side in terms of price, and then we have orthokeratology. So we'll have to really look forward in these areas, and to see that how we can strengthen the collaboration, how we can work together, because it is really important that once any optometrist sees a patient, they take the history, they understand there's a family history of myopia, and either the parents are using, if at all they're in history of any glaucoma or any other diseases. And one thing recently, I was speaking at a myopia conference where it was talked about the choroidal changes which is happening once the axial length is increasing. What are the changes happening in choroidal thickness? So probably in future we'll have to also, beside axial length, we'll have to also see the changes in retina, and probably OCT will also come into a picture as a regular. So we have to really go beyond our professional boundaries and work as united as a community. So we'll have to just work on these lines. Thank you. Thank you so much.
Thank you, Dr. Rajiv. Thanks a lot. Dr. Neha, if you have some quick inputs, please go for it.
Yeah. So thank you for this very relevant question. I strongly believe that tracking myopia globally requires a unified, undisciplinary approach, and our organization and ophthalmology communities must work hand in hand rather than silos. And we can definitely collaborate on public health drives, on campaigns, on common advocacy, on policy advocacy, and standardized protocols. So this is how we can do and collaborate on many fronts.
Absolutely well said, Dr. Neha.
Thank you.
I think now we change gears and we talk about the World Optometry Day. So because we were commemorating the World Optometry Day celebrations also, which just went by on 23rd of March. So I would like to hear from Dr. Mohita. She's in a leadership position both in WAS, WOW, and now the All India Ophthalmic Society also. Dr. Mohita, there are these very important organizations, and we have about 75,000 optometrists in India. So if we talk about India and then what do you think that where optometrists can be aligned with our goals and how they can be a very strong support for the common mission we have to reduce the prevalence of avoidable blindness? What do you think are the newer things what you can suggest in under your leadership?
Thank you, Dr. Samina, for inviting me and for conducting this webinar, a very important webinar. And uh, the question you have asked is about collaboration between ophthalmologists and optometrists. I feel in today's world, we both ophthalmologists as well as optometrists have to get together and kind of co-manage diseases. This is what already we have been talking about in the last 2 hours. And as of now, I still feel that ophthalmologists are as well as optometrists have kind of a divide between them, and they are not together, though they are kind of are they are working for the same cause. So unless and until they come together, we are not, unless and until we come together, we won't be able to manage diseases as they should. Now, there used to be ophthalmology setups, which used to be run only by ophthalmologists, but today we find that ophthalmologists cannot survive without optometrists, whether we want to believe it or not. But we are like one team, and similarly, I think it's vice versa. So we both kind of need each other. So, as far as what we can do about it to make this bond stronger is, one is, I feel, as organizations, one is that we should get together as ophthalmology organizations and optometry organizations and clearly define what individually is the role of optometrists, what individually the role of ophthalmologist, what legally an ophthalmologist can do, and what legally an can do, so that that conflict goes away, and we know that these are our clear cut activities that each segment can perform, and then there are some activities that both can perform together. So once this conflict goes away, there is going to be a partnership. So first is we have to remove this divide and get them all together, and this can be done by defining the activities of each and defining the rules of each. That is one. Secondly, once this is done, uh, then uh, uh, then um, then opportunities where there are platforms for both getting together would be the next step. For example, in our ophthalmology conferences, we find that there are hardly any optometrists because they are not invited. So somewhere we have to make this change where 30% of our sessions could be optometry sessions. Otherwise, we find that one small hall, there may be something related to contact lens, and that's all which is there related to optometry. So now that so much of changes have happened, when we are talking about myopia is something where both ophthalmologists and optometrists are working together on it. And even if we see from the patient point of view, if a patient goes to an optometrist or goes to an ophthalmologist separately, and if there is a conflicting opinion between the two groups, then the patient is going to be dissatisfied. It should be the common language that we all should be speaking. Now that common language will come only when we are commonly on common platforms. So thank you for creating this platform, and here we are together speaking, and speaking as well as understanding a common language, which will actually be this will be translated to our patients. So whatever Dr. Rajiv says, Dr. Samina is also saying that, and vice versa. So then there is no confusion in the mind of the patient. That is one. Then another thing, while Dr. Vasudha was speaking, that came to my mind right now only, and I had not thought about it till now, but one common thing that we could do together is research. And research is something which whenever we have tried to work a lot on research activities with many ophthalmologists, and as you know, in Women in Research and Women Ophthalmology Society, we do a lot. But there is one common thing that we find with all ophthalmologists: they say, "I do not have time for research." So when optometrists and as well as ophthalmologists are together, this is one thing that they could really work on, and this is something which is the need of the hour, because as of now, what kind of research do we do? A pharma company will do a clinical trial and tell us that this product is good, and we start doing that. But there is nothing that we have analyzed ourselves. So all the research is driven by sponsors. So if they say that LDA 0.01% is good, we start saying it is good. When they say 0.05% is good, we start doing that. Dr. Jitendra Jithani is sitting here. We from these sponsored trials, we have made guidelines for myopia, and then we follow those guidelines, and then a company is elated, and they because of those guidelines, and they spread all the guidelines everywhere. Yes, we are thankful to the companies that they help us doing all this, but then why should that initiative not come from us? If it comes from us, it will be totally unbiased initiative, and it will be more true results, because it will be we could do kind of head-to-head comparisons also. There are hardly any comparisons between LDA and myopia control glasses. Now, there are hardly any comparisons between two type of myopia control glasses. So this is something which can happen from our side, and this is something which you tell only ophthalmologists to do. They will always say, I don't have the time. But if you have the ophthalmologist and optometrist together, then we become a bigger resource, all of us together, and we could do these research activities. So that's something which came to my mind, Dr. Vasudha, while you were talking. Thank you for giving this idea and generating this very important idea. And the third thing that I was thinking was we could do some exchange programs. Like if you look at ophthalmologists, I'm talking from ophthalmologist point of view, and to the optometrists, then things like orthoptics is a forgotten thing. Uh, Again, Dr. Jethani talks about it. Then we start remembering, yes, this is also important. Something like binocular vision is a forgotten thing. Only, pediatric ophthalmologists would know, but general ophthalmologists won't even know what it is. They had read it in their post graduation times, and after that they have completely forgotten it. So these are, and in myopia, when we start talking about myopia, we start talking about accommodation, AC by A ratio, accommodative lag, etc. And if you ask most of the ophthalmologists, they'll just remember these are some terms, but what exactly they are and how to practically use them is not what they know. So optometrists have a very strong base in all this. So if we learn, we could kind of learn from each other so that we'll manage patients better. So these are the things that were coming to my mind. There's lots to do, and I'm sure with platforms like this, we can take some of these things forwards.
Thank you, Dr. Mohita. I hope you saw all the claps which Dr. Raji was sending your way when you were telling, and with the hope that in the next AI or OS conference and the next Women Ophthalmologist Society conference, we will see optometrists also. So that's something which will be
Definitely we will see. So that because boss is you and me, AIOS, yes, we'll try.
Please do
try
try
convincing them.
with full heart. And thank you very much. And you will be happy, Dr. Mohita, that under the leadership of Dr. Vasudha Kemanu, she is at the Children's Hospital at Zamindar's, and generally at Zamindar's Hospital, we have a team of research which is co-piloted by the ophthalmologist and optometrist. And we do some very meaningful research in pediatric department and also in other departments like glaucoma, for family members who have come for glaucoma evaluation of glaucoma patients, and all those small research topics are being taken care by the optometrists. So like what you rightly said, ophthalmologists do not have that much time, and our optometry team are now partners in research with us. So I also thank my optometry team. If any one of them are here, thank you very much. Now over to Dr. Vinod Arora, sir. Sir, you understand that I want you to now speak not as a leader in ophthalmology, but as a private practitioner in Dehradun. That what do you think in your position there you can do to empower the optometrists around you and to create a culture of collaboration? Something what you can think, and then all of us can also take it forward.
So, as a senior ophthalmologist, I've been working for the last 36 years, and I have witnessed firsthand that empowering optometrists has helped us to reach so many milestones. For the just like we had the blindness control program and other various activities. So with the help of optometrists only, we can achieve this. We are a population of 1.5 billion people. And I think the number of ophthalmologists may be around 50,000 or even less than that. So it's not possible for ophthalmologists to cover all the aspects. So we require all the persons to manage eye problem. We have to have a holistic approach. It starts from prevention. We have to have school teachers in that. We have to opticians, we have to optometrists, ophthalmologists, ocularists, even the trade. When all they combine, we can provide eye care to all citizens of our India. That's a very, very big country. So we have to have, I think Dr. Samina, you have showed a very good platform where we can combine, and last the meeting we had with Indian Optometric Association and our AIUS, it was a very, very fantastic that session. And similar session, if we can keep on other conferences, Dr. Mohita is here. So we'll keep on these sessions together and we will share some things. And as Dr. Mohita has rightly said, we have to have a collaboration protocol also. We have to have divide what is recommended for optometrists, what is the role of ophthalmologist. It should be clearly defined. So there should be no conflict, and we have as a team, we can work together all over India, all over world. So we have to take training initiatives. Maybe some of the ophthalmologists can mentor, some of the optometrists can mentor. We can train general ophthalmologists and general optometrists in various things. Like as the optometrist, I have a lot of limitations, especially for the specialty contact lenses. So I don't understand much because I don't have time unless I go a workshop or teach there. So it's going to improve my understanding, my skills also. Similarly, optometrists can learn a lot. We can give them a lot of things to learn, including tonometry, visual fields. That will free the ophthalmologist for doing so many things. So if these things are taken care by optometrists, and clinical part which is meant for treatment only, that is taken by ophthalmologists, that will save a lot of time and provide a lot of manpower to handle that thing. So I think we have to have advocacy and recognition. The platform you have created, I think, is very, very wonderful, and we should go again, improve it, involve all the persons, involve the trade also, involve optician also, and involve the social worker also. So that's going. IU has taken this time a very strong initiative for myopia management. They are going to provide structural guidelines. They go provide education, and what Dr. Mohita was talking as a research also to tackle the prevalence of childhood myopia in India. We are just seeing almost an epidemic in India. Almost 50% of the population is going to be myopic soon. So unless we as a team tackle it, it's not going to be solved with any means. Thank you.
Thank you, Dr. Vinod. Thanks a lot. I see that Dr. Rajiv has raised a hand, and I'll come to Dr. Rajiv shortly. But before that, I would now request Dr. Senthil. Thank you, Dr. Senthil. You're such a busy person, and you've joined this meeting, and you've stayed back with us. So I really appreciate that. Dr. Senthil, you're doing something new every time I meet you. You tell me something new, and recently I was informed that you've started a training academy for optometrists. And because ICA stands for optometrists, for empowering optometrists and helping ophthalmologists. So we are very interested to learn more about this training academy. Please do share more about it.
Yeah. Thank you, Dr. Samina, for this introduction and the opportunity. We at Oftal actually believe in execution, and very happy that this has come up. Basically, we launched this Oftal Academy yesterday in Chennai. Maybe let me just share the thing if you can. There is some advertisement coming. So yesterday we started this academy by Dr. Mohan Rajan, who is the president-elect of AAOS, and Dr. Anuja. She is also a part of this program. She was from Shankar Nethralaya, and she has joined us. So basically, whatever we discussed, I feel there was a huge need. I've been working on it for the last 3-4 years. And then I thought, let us start not the regular optometry courses which are run by eye hospitals, but an academy which will be the collaborating partner between eye hospitals and optometry colleges. So basically what we understood was there are so many optometry colleges all over India. They are in need of good internships. Basically, the 3-year course is done in the optometry college, and there are interns who wants to do the 4th year in hospital. So, Optal Academy will kind of connect the optometrists from premier schools or any kind of optometry institutes to good doctors, like for example Dr. Samina or Dr. Vinod Arora. So basically the 1-year internship we will do, but something which we are trying to do different is basically also monitor and train that optometrist during that 1 year of internship also. Apart from being posted in the eye hospital, we will also be conducting online sessions. There will be a mentor who will monitor them so that they are hospital ready when they complete that internship. Most probably we will help them get employment in that particular hospital itself. Our target is to have train almost 300 interns during the first year, where they'll be going to various hospitals. We are signed up with very large corporate hospitals, institutions all over India, and at least 5 universities have signed up collaborative effort with us. The second thing which we plan to do is basically what we understand is many of the optometrists work in eye hospitals, but there is no skill upgradation for them because day in and day out they become practitioners, but they are not upgrading the skills. For example, in binocular vision or orthoptics, so we start fellowships. Basically, we are offering. We are starting with four fellowships: binocular vision, contact lenses, clinical optometry. These are the fellowships. So the optometrist, while working in your hospital, can also attend these sessions. It's like a hybrid program where they attend online and they also can get the practical experience in the eye hospital. So that's something which we are launching. Third thing is there are so many optometrists who are diploma who want to get BSc, or who are BSc who want to get MSc optometry, or some of them wants to have PhD. So we will also be associating. We have already partnered with a leading university in Chennai. So to offer these courses also to these optometrists. So these, and what fourth thing which we are thinking is there are so many optometrists working in rural areas, maybe diploma or vision care technicians who don't have the expertise or skill upgradation. So we are also working on skill upgradation for them. So basically, whatever we are discussing, we are also trying to get into the regular model of actually going in and executing it. So incidentally, we started the academy yesterday, and this is the thing from the Hindu, Chennai Hindu, where you can see Dr. Mohan Rajan, and there is the chairman of the Amet University from Chennai, and Dr. Anuja. She is also part of. She is the principal of our college, and Mr. Vishwanathan, Dr. Vishwanathan, he is from Shankara. So it's a kind of a collaboration which we've already established, and we would be happy to associate with the Optometry Association, and also we have already signed up MOUs with the 30 eye hospitals to absorb the interns. So that is something which we are trying to do, and we would be happy to associate with your platform also for the same. Thank you, Doctor.
Thank you, Dr. Senthil. We are very glad that you joined in our webinar today. And the ICA was formed with with only one pure intention, to sort of help each other, and in turn, at the end of it, to help the communities. So we have we are here with a heart of gold, and whatever the 8 founder members who are here from ICA today are very happy to associate with you, Dr. Senthil, and with your work. And we will continuously be doing something different and new. And wherever we can align, we will be very happy to align. And I request you that you keep the same intention and do align with us, and we can together work, because there's a very short life everybody have, and there is so much to do. So we're very happy that you're doing this fantastic work. And at ICA also, we are looking at opening up observerships, not internships right now, but observerships, which will be completely free of charge. There's nobody paying any money, but people will come, and if there are any of optometrists who would want to visit any of the ICA network hospitals, they are it is a free observership for about a month's time, and there will be sharing of knowledge. And there are so many things which are not tangible, intangible things which the optometrists will learn when they visit these institutions. So we are looking at partner eye hospitals across India in every city, about 3 or 4 partner eye hospitals for ICA. So please do keep that in mind. Of course, we will slowly start associating and seeing that they all become a part of ICA. So thank you very much. Rajiv, you wanted to say something, and then we will. Can we all also on their cameras for a group picture? But Rajiv, over to you for your last comments.
Thank you, ma'am. I think, one thing which actually, we had discussed earlier initially that, the point which, especially which Dr. Mohita brought up about research. I think, research is one area where I think we'll all should ideally work together. And a lot of, most of the research when we talk about it is industry funded, but, research on ground, there are a lot of things which are needed. And I think that is something which really have to look at, to get into. But I think fantastic, all over, the webinar went really, really well. And I think all the inputs are really, really so nice. I mean, I'm so sorry I'm unable to open my camera because I'm on the way. But I must say that, it's a great start, and let us keep working. Thank you.
I'll just request quickly that if you can on the camera, and I'll take a screenshot so that we will remember this moment. Thank you. Thank you, everybody. Thank you for participating in this webinar. A happy World Optometry Day once again to everybody. And I special thanks to all the speakers for your time, all the expert panelists for your time. And we meet again after 2 months for our third webinar. Thank you very much.